Always a pleasure to come to Bathinda, and Mapicon, I must say, has grown over the last couple of years, and Vitul has taken it as an obsession with him, and anything that you do with obsession obviously will provide more returns. And the presence of all of you only entails the great amount of work that he puts in throughout the year. I would like to congratulate Dr. Ravinder for this beautiful discourse, one of the best lectures I've ever heard on lipids, covering all the aspects. Coming to my topic, I think the reason Vitul chose to give me lipids is because in the last 1 or 2 years there has been significant change in terms of how we think we should manage patients with hypertension. And we were responsible for writing 3 editorials, one in the Circulation, one in the European Heart Journal, and one in the Indian Council of Medical Research Journal. So for that reason, I think he thought we can discuss. Let me dedicate this lecture to the most respected, loving individual on this earth for me, my father. And incidentally, I and Dr. Vitul both lost our parents, our fathers, in the last year. So I thought we must dedicate this talk to the great memory of whatever we learned and whatever we are due to the wishes, desires, hard work, and whatever moral values they could inculcate in us. The topic, as I said, that he has been is given to me is on new hypertension guidelines. And what are guidelines? Basically, they are what people, whatever evidence base today we have, that is grouped by some experts and put it in a simplistic manner so that one is able to interpolate it towards better practices for patient care. And my endeavor for the next 20 odd minutes would be, at the end of this talk, whether you are a cardiologist, physician, gynecologist, obstetrician, you should be able to treat hypertension as well as all of us sitting in this hall should be, so as to simplify this whole issue. Because unless we all treat hypertension similarly and we are equally kind of capable of managing hypertension, only then will the purpose of this talk be fulfilled. And I'll try to make some observations in terms of how we look at hypertension and how we are becoming more and more aggressive in terms of targets that we achieve when we manage patients of hypertension. We all know we live in a world which has a population of about 8 billion, and out of them we have 1.2 billion people who suffer from hypertension. It is the commonest non-communicable disease in the world, and almost 25% of the world population. So 1 in any 4 individuals above 30 years has hypertension. And it's responsible for most deaths, almost half the deaths due to stroke, half the deaths due to heart attacks. They are because of high blood pressure. And you all know we are a very populated nation. What percentage of the world population we comprise Indians? Anybody? India and China are the largest. Almost 18%, 18 to 19% of the world population lives in India. So almost 25% of the world population is in South Asia. So we form a very important part, and our genetic, social, economic, how we eat, how we walk, all those methodologies are different. We are genetically different. People say we have a thrifty gene. There's Dr. Ravinder was just showing a man with a paunch. We have a central kind of an obesity. We have high metabolic syndrome X. And he was saying our lipid profiles are different. So we cannot interpolate Western guidelines and Western data and then start managing our patients what they say. Of course, we should not be blinded to what the world is looking at. We should be aware and conscious of what the world data is, because we cannot interpolate and create that data here. But in this country, we know we looked at about 25 years, 30 years back, we saw what the prevalence of hypertension was, almost 15% in the rural area adjoining our city. And recently we published this article in the Heart Asia, where we found that the prevalence of hypertension in the same group of people has increased from 14 to almost 25%. So we virtually caught up with the world prevalence of hypertension. Of course, over these 25 years, diabetes has gone up. Almost 10% of people in India now have diabetes. Obesity has gone up, and Dr. Raju Singh is going to give you an excellent lecture on the non-pharmacological methods for treatment of obesity, and we really look forward to that talk. And this has also resulted in increased prevalence of coronary artery disease, which we today know in the urban areas it is about 10%, and in the rural areas it is about 5%. So there is a rural-urban divide. The people are brothers and sisters who are in the urban area, they genetically might be the same, but we have a lifestyle, since these are not just genetic diseases, they are also lifestyle-related diseases. All non-communicable diseases have a lifestyle aspect as to how they happen. And as he showed, the seeds for obesity are started in childhood, and urban children, we found the prevalence of hypertension was much higher, 6%, as compared to rural children where it was 3%. As they get obese, they have more hypertension. So all these dyslipidemia, diabetes, hypertension, central obesity, they are close cousins. They tend to happen together in the same individual. Now this is another aspect of hypertension which is pretty bad. If you look at the awareness, treatment and control rates in rural and urban India as compared to United States and in many other parts of the world, we fare pretty badly. So if you have to impact any form of treatment, if you and I have to make a difference in terms of public health, public awareness of treatment, spending time so that compliance issue is handled in these people, the drug that you choose is not going to make that much of a difference. But whether your patient is compliant with the therapy or not, that is what is going to make a difference, and that is what we need to spend time upon. Why we treat high blood pressure? Almost half of them are going to die of heart attacks, almost 1/3 of them are going to die of strokes, and about 10 to 15% of them have renal failure. They can have dissections, they can have other peripheral artery disease, other consequences of hypertension, but this is how most patients of hypertension will be eliminated. Now when we all grew up, the guidelines that we were using for hypertension were the JNC guidelines. These were American guidelines, and we all grew up learning about the JNC guidelines. And we all know diuretics and beta blockers were the first agents. And what was the commonest drug that we all used? Most of the senior physicians, Dr. Grover is here, will bear with me. We used to use tenochlor, was a very popular beta blocker, and a diuretic we used to use very commonly at that time. And these were the only agents that were available with us. But subsequently we had calcium channel blockers, ACE inhibitors, receptor blockers which came later, and there, for many years there was a comparison being made as to whether old is good or the new that we have got now in form of calcium blocker or ACE inhibitor or ARBs, what is better. And if you look at these, a lot of these guidelines that came till 1997, diuretic or beta blocker. Diuretics were considered as the kind of the drugs, and we were taught and told and practiced that diuretics should be the first agent that we use in these people. But then the JNC went out of vogue, and now we are going to talk about these new guidelines which have come. We formed the Indian guidelines first in 2001, then we updated them in 2007, and then we came out in 2013. Now this year, by the end of this year, we'll come out with the latest Indian guidelines which will incorporate some of these things. This particular, I'm not going to bother you too much with data, hard data, but this is a study which all of us should be aware of. The SPRINT trial, which is an American NIH trial done in 170 centers, and this is one of the few trials which got terminated halfway. Now the data management board never terminates a trial halfway unless the difference between the two arms is very significant. And here what they were looking at, they were looking at if we treat patients to a target of 120 blood pressure as against 140, which was the practice till now, till 2015. And what they found in this particular study, and what kind of patients they took, they didn't take very severe hypertensive. In fact, they took people who were in the normal range, 130 to 180 blood pressures, but they had higher risk like cardiovascular disease, CKD, their 10-year risk was more elderly. A lot of us were taught when we were doing our graduation that age plus the 100 plus the age is the acceptable blood pressure. We were at times taught that elderly people tolerate more blood pressure and we should accept higher blood pressures. But then some trials came which showed us that systolic hypertension, which occurs in elderly, and diastolic hypertension occurs in the younger people. And we all know the commonest age for occurrence of essential hypertension is, when do people get hypertension essential, is between 30 to 50 years. After that, it is atherosclerotic disease, it is aging phenomenon, and then people start coming to you with isolated systolic hypertension or predominant systolic hypertension. So if someone has to have a hypertension, what I said, 1 in 4, it will occur around 30, 40 years. It's not surprising that you start saying that this is a young guy. That's the age when essential hypertension occurs. So these guys looked at people who were having blood pressures in the range of 130 to 180, and they targeted in the intensive arm a blood pressure of 120, and in the less intensive arm something that we were doing. We were happy our blood pressure patients we could treat to 140 by 90. We said fine, I am treating my patient well. But what they found was a significant difference in deaths between the two arms, and so they terminated this study. And so there has been a kind of, I would say, a plethora of guidelines have come after that, because they want us to impact mortality to a greater extent. Just as Ravinder was saying, treat lipids to lower levels in Indians, because we have different dyslipidemia, we are metabolically different, genetically we are more prone to heart attacks. South Asians who have migrated to any part of the world, see, initially we were migrating our people, Gandhiji went to African countries and East Africa, and from there a lot of Indians at that time went. Then people started going to Singapore, Malaysia. Then in 60s and 70s, a lot of Indians went to England. Then they started going to Canada. Now they're going to Australia. We are explorers basically. And wherever we have gone, it's been seen that South Asians, whether it is Pakistanis or we can have political differences, but genetically we are same. We have 10 years earlier heart attacks. And that's the reason these risk factors have to be treated more aggressively, because our forefathers lived with a thrifty gene. And what they call, McCaig called it as a thrifty gene hypothesis. A lot of Indian experts don't like it, but this is what the factor is. And we have a male pattern obesity, we have more paunches, we have central obesity, and we have higher heart attacks occurring earlier. And unless we control hypertension, dyslipidemia, diabetes, obesity, these things which Vitul has kept for today, we will not be able to impact mortality. And so I'll just take you through some of these guidelines, the American, the European, and this is what our Indian guidelines say. Even within the normal range, if someone has a blood pressure of 115 by 70, for every 20 millimeter systolic rise and every 10 millimeter diastolic rise, the risk increases by 2 times. So whether you are looking at blood pressures in the hypertension range or in the normal range, risk increases from that. That's why optimal blood pressure for an individual is 120 by 80. But as it goes up, we in the Indian guidelines define normal is 130, less than 130 by 85, high normal. What the Americans at one time said pre-hypertension. We didn't accept this, but they called it as pre-hypertension. And isolated systolic hypertension, as I said, so you keep adding 20 to the systolic and 10 to the diastolic blood pressure to go from 1, 2 to 3. Now the European guidelines which have come this year are exactly the same as what we had given in 2013, the Indian guidelines. So if you're looking at the European guidelines, the latest, they are the same. But this is what has caused a storm, and this is what is a media kind of a rage these days. The Americans redefined hypertension last year, inspired by the SPRINT trial. They said hypertension is to be defined beyond 130 by 80. Now something that you and I were taught, hypertension is beyond 140. Tomorrow somebody says diabetes is to be redefined, you will obviously be kind of scandalized. So similarly, hypertension now has got redefined by the American College of Cardiology, AHA, from 140/90 to 130/80, and that's the reason I'm talking on this topic, and that's the reason there is debate, discussion, lay press, media is looking at vigorously, because the prevalence of hypertension in the American population is about same as us, 28%. But if you take 130/80, then the prevalence of hypertension goes to 42%. So virtually 1 in 2 individuals from a 1 in 4 individual has hypertension and would be treated. So this is what is causing concern, and this is what we will try to thresh out what it is. Now the second major change that has occurred over a period of time is, we always had lot of faith in the mercury sphygmomanometer that you and I use, and we had lot of faith in the office. Patient आके कहता था कि जी मैंने घर च मैं डॉक्टर साहब blood pressure कराना, मेरा blood pressure था ठीक आंदा है, ਤੁਹਾਡੇ ਕੋਲ मैं आना मेरा blood pressure ज़्यादा आंदा है. We all were taught as students this is white coat hypertension, but we never realized that it's the home blood pressure, it's the ambulatory blood pressure which correlates more with complications. It is not the office blood pressure. And so as a policy, the Canadians came up first. Now all of us depend more upon the home blood pressure, and that is the significant change in guidelines that has happened. Look at the ambulatory blood pressures, which are not practical, which are expensive. I'm not advocating at all here that you start doing ambulatory blood pressures, but only in a very highly selective. But home blood pressures are to be done. Home blood pressures is the way, just as diabetologists look at home blood sugars, we need to look at. And the parameters for home blood pressure is whenever the blood pressure is more than 135/85. Now if you're doing an ambulatory blood pressure, it is more than 130/80. So office blood pressure 140/90, home blood pressure 135/85, and ambulatory blood pressure more than 130/80. That is the definition of hypertension. Now how we record blood pressures, invariably you are all busy physicians, you'll ask your nurse or you'll ask somebody else to record. But blood pressure recording is the most important aspect, because not only is your treatment going to depend upon the technique. This is the trial which we did last year, a couple of years back. It's an ICMR funded study where we found very few of us are actually recording blood pressures of our patients in the right technique. And we need to do away with the mercury apparatuses, because the WHO says don't use the mercury blood pressure apparatuses. So what are the kind of peculiarities that you and I have from others? We all know hypertension occurs a little bit earlier amongst us. There is a almost 25 to 30% rural-urban difference amongst us. And as I said, we have multiple risk factors. In summers, our blood pressures go down. In winters, our blood pressures go up. We've published some of this work last year also. In winters, you have to up-regulate the therapy, and in summers, you have to down-regulate, because otherwise patients will come with hyponatremia, they'll come with hypotension. And also the prevalence of hypertension in our population is going on. Why? Because we are very high salt intakers. Average Indian diet contains 8.5 grams of salt. If you compare it, what the American guidelines say is 3.7 grams of salt take every day. What all these achars, papads, all these things that we take, they are all very high in salt. And we add extra salt to whatever we take. And that's the reason we are one of the highest salt intakers. Even our guidelines, in fact, we are only trying to achieve a salt intake of 5 to 6 grams per day, which is almost double of what the Americans say. I was given 40 minutes. Please, I have to do justice with this topic. I'm sorry. So look at the amount of. This is what is going to make a biggest impact in terms of how we will be able to reduce the prevalence of hypertension. So just to reminisce, office blood pressure is not the only you need to depend upon. Office as well as out of office blood pressures and ambulatory blood pressure wherever it is feasible, wherever you. Now this is a term which I thought I'll share with you. AOBPs, automatic office blood pressure, because it has been recognized that white coat phenomenon occurs. Patient comes, now the Canadians say the best way to diagnose hypertension is automatic office blood pressure apparatus. Now these are apparatuses where the patient walks into the clinic, is left alone in the room, the doctor walks out. After 5 minutes, these apparatuses start doing blood pressure. They take 3 recordings and then give you an average. That is actually the true reflection. So you will hear of these AOBPs, the automatic. These are some of the sources. True BP has been the most popular, but now we have the Omron and the Pro BP. So these are some equipments which have come of late, which Canadians in their guidelines advocate as the first choice agents for maintain. And this is the equipment which was used in sprint trial also. And something that they have against the sprint trial is, because this method was used, the readings are 10% higher than what you and I record in our offices. So maybe we have to target little bit higher than what the sprint study showed. And since the sprint study showed 120 by 80, so we are looking at, most of the guidelines are today saying 130, because that level is little bit higher with the office recordings that you do. And that's the reason the Canadians also feel, the Europeans also feel, that somewhat higher pressures than what the sprint looked at. We need to develop and look at our own guidelines. And besides the lifestyle methods that you use, this is the simplistic algorithm that we have given for management of hypertension. In younger people, here we don't take age. Younger people for hypertension are less than 50, because that's the age when essential hypertension, if it had to occur, has occurred. Older are beyond 50. Use a ACE inhibitor or a receptor blocker if the patient is young. That's your first choice. If the person is elderly, use a calcium channel blocker or a diuretic. So that's the first agent you use. As a second step combination that we suggest in the Indian guideline, pick one from the left side and pick one from the right. Don't combine diuretics with calcium channel blockers. Don't combine ACE inhibitors with beta blockers. So you use a ACE inhibitor or a receptor, and never combine a ACE inhibitor with a receptor blocker, because so don't combine. Receptor blockers are losartan, candesartan, and ACE inhibitors are ramipril, enalapril, lisinopril that you use. Receptor blockers are very commonly, in fact, they are one of the most commonly used. Telmisartan is olmesartan, now azilsartan. These are some of the most commonly used drugs, and these are all receptor blockers. So never combine a receptor blocker with an ACE inhibitor, because you'll have more hypotension and more hyperkalemia. As a step 3, then you combine ACE inhibitor with a calcium channel. So this is the most simple algorithm that you will use for now look at the Canadians. We were advocating single pill therapy because it improves compliance. Now the Canadians are also looking at single pill therapy. On thiazide diuretics, we have always been using hydrochlorothiazide, but the agent of choice is chlorothiazide, because it has longer action, so it has a more smoother effect on blood pressure. Now this is the Americans. What they have said is, first line agents are thiazide diuretics, calcium channel blockers, ACE inhibitors, receptor blockers. They don't even mention beta blockers as the first line agent. That has been the change in beta blockers. Beta blockers have risen. Now today beta blockers are the drug of choice for heart failure. All patients of heart failure. We were taught that heart failure beta blockers are contraindicated. Today, whether it is class 1, 2, 3, 4, any heart failure, symptomatic, asymptomatic, only patient has acute heart failure, hospitalized, you want to stabilize then, because beta blockers are one of the few, or one of the 3 group of drugs that reduce mortality in heart failure. One is beta blockers, second is ACE inhibitor receptor blockers, third are mineralocorticoid receptor antagonists, spironolactone, eplerenone. So beta blockers have risen in their reputation, whether it is coronary artery disease, whether it is heart failure. They are class 1 agents for all patients. But in hypertension, you can see they came for hypertension, and their story has been of a rise and fall, and today the Americans don't even count them. We in our Indian guidelines say whenever there are special indications. Or you have young people, there are a lot of young ladies, young men, who will come to you with a fast heart rate, they have tachycardia, they have increased sympathetic activity. Beta blockers produce the best effect. So in the Indian guidelines, we still advocate use of beta blockers, maybe newer beta blockers, which do not have, why beta blockers have gone out of disrepute in this chronic disease is because they cause dyslipidemia, new onset diabetes, these are the metabolic side effects, and when you are using a drug for years, for decades, these metabolic effects become more important. But when you are using in heart failure, it doesn't make a big difference. So that's the reason beta blockers have gone. So actually, I don't even want you to bother too much about what I have said till now, ye dawai achhi hai, ye kharab hai. because we never treat hypertension with single agent. These neurologists will come and tell you that in epilepsy, use one agent, highest possible dose, because they are trying to suppress the electrical activity. Hypertension treatment is opposite. You use multiple drugs with synergistic action so that there is increased action. Now it's been seen that rather than increasing the dose of a single agent, when you combine another agent, the effect increases almost 5 times. So the philosophy of treatment of hypertension is multiple drugs, low doses, and now something that was happening in India is happening in other countries also. Single pill combination therapy has come, and now the Europeans are also looking at, and the Americans are also looking at this, that use multiple drugs rather than keep on making one particular drug more effective and strong. And this is the simplest algorithm which Europeans have now given this year, which is not very different from what we showed in the Indian guideline. Ya to use kare ACE inhibitor or receptor blocker, combine with CCB or diuretic. That should be your first line. You can combine losartan with amlodipine, you can combine candesartan with amlodipine, or you can combine an ACE inhibitor, lisinopril, ramipril with chlorthalidone. That's your choice. Second step, use 3 together, all 3. Beta blockers are not there, mind you, in the latest guidelines. Step 4, as the fourth add-on drug in resistant hypertension now, the drug that is considered drug of choice is spironolactone in a dosage. So this is a potassium sparing diuretic, a mineralocorticoid antagonist, which is to be used in the dosage of, because the pathway studies from UK showed that as compared to, a lot of us were using mini-press, this prazosin, a lot of people were using tirazosin, some of us would like to use amiloride. Now this was compared with beta blocker, with alpha-1 blockers, and what they found was spironolactone impacted almost 20% of the individuals with resistant hypertension. They have aldosterone antagonism, and they need to be put on these antagonists so as to reduce their blood pressure. So single pill combination, whether it is a double therapy, triple therapy, the Europeans are talking of. So if you are practicing multiple drugs in a pill, that's the way people are treating hypertension. Now let's look at 3 or 4 special situations before we part. Diabetes, the target should be 130. Now the European guidelines for the first time ever have given the diastolic also. We were looking at the systolic. They said don't reduce diastolic blood pressures to less than 80, but bring it down, less than 70, but bring it down to 80, because there is a steal phenomenon which occurs in these people. Patients of CKD, don't be scared of using ACE inhibitor receptor blocker, but monitor their potassium levels because they can develop hyperkalemia. Of course, very good drugs are calcium channel blockers and diuretics in this particular situation. Now, how does hypertension affect heart? You all know it causes heart failure with preserved ejection fraction, and then ejection fraction start going down. The agent of choice in heart failure preserved ejection fraction is diuretics, ACE inhibitor receptor blockers and beta blockers. But we know that all these agents, they impact mortality in heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction, don't go very high on the dosages, only control their blood pressures, because beta blockers, ACE inhibitors don't impact mortality in heart failure preserved ejection fraction as they do in low ejection fraction. Again, in patients with heart failure, low ejection fraction, use these 3 agents, as I said. Avoid calcium channel blockers because they have a negative inotropic effect. The dihydropyridine calcium channel blocker amlodipine has lesser or very minimal negative inotropic effect. Verapamil, diltiazem should never be used in any person who has LV dysfunction. Any person who has a low ejection fraction, don't use verapamil, don't use diltiazem. Amlodipine only use in people with low ejection fraction when you are wanting to treat their blood pressure after you have used an ACE inhibitor or a receptor blocker, a beta blocker, diuretic. As a 4th choice, you can use this. Patients with LVH are to be similarly treated just as we treat patients with heart failure ejection fraction, low ejection fractions. Now, coronary artery disease, we used to feel there is a steal phenomenon, but the latest guideline says don't reduce to less than 120 by 70, but try to achieve a blood pressure of less than 130/80 whenever you are treating post-MI patients, angina patients, post-CABG, post-PTCA. That should be the target where you are trying to reduce blood pressures. Now let's look at one other area, pregnancy with hypertension. We know alpha-methyl dopa is the drug of choice. The second agent that is the second and more commonly used today is labetalol. And the third is amlodipine. The drugs to be avoided are ACE inhibitors, receptor blockers, and diuretics. Now, there was a consensus that we treat blood pressure when it is more than 160/105. But in this CHIPS trial which came last year, it's been seen that when you are targeting a blood pressure of less than 85, as against when you were targeting a blood pressure of less than 100, which was our practice earlier, severe hypertension occurred less often, fetal loss occurred less often, eclampsia, pre-eclampsia occurred less often. So pregnancy with hypertension, our approach is little bit more aggressive now. Let me share another area where our approach is less aggressive. Now if a patient comes to you with acute stroke, if the blood pressure is less than 220/110, do not treat their blood pressure in a patient with occlusive stroke, because there is altered autoregulation. You will make them worse. But if you are using thrombolytic therapy, now neurologists are using thrombolytic therapy. They cannot use streptokinase as cardiologists can use, but they can use alteplase. They have even started using tenecteplase now in acute stroke. Their window is less than ours. Their window is shorter, about 4 hours. Our window is 12 hours. But whenever you are contemplating thrombolysis, it's contraindicated whenever blood pressure is more than 180/110. First, bring the blood pressure down. Now, we all know that in occlusive stroke, there is less circulation. So we don't treat hypertension. Now, how about hemorrhagic stroke, which has occurred because of a high blood pressure? What should be our approach? This trial which came last year, the ATTACH trial, looked at how aggressive should we be when a patient of acute hemorrhagic stroke comes to us. Mind you, almost 25% of strokes are hemorrhagic, 75% of them are occlusive. We believe that Indians have more frequency of hemorrhagic strokes than in the Western population. Now, in this particular study, the ATTACH 2, it was found that a more aggressive approach, bringing it down to 110/140, did not make any difference. So still a sober approach in patients with hemorrhagic stroke, with occlusive stroke. Hemorrhagic stroke, accept blood pressures to 180. Occlusive strokes, accept up to 220/110, and don't treat them for the first 48 hours. After that, of course, they will behave like any other person, and a post-stroke patient, your treatment of blood pressure has to be as aggressive. So what we have come today is the threshold for treatment of hypertension today is not 140/90. If you have a person who is more than 75 years, mind you, elderly people are more at high risk. You are more aggressive in elderly people because you get more benefit of treatment. Person who has multiple risk factors, person who has coronary artery disease, person who has CKD, start treatment at 130/80. A person who is otherwise healthy, usko koi diabetes nahi hai, koi dyslipidemia nahi hai, kuch risk nahi hai, no CKD, you can even be complacent because that's a lower risk individual. In fact, that's the philosophy of medicine. Whenever you intervene in a high risk situation, you will impact mortality more. Whenever you intervene in a low risk individual, you will impact mortality less, because as such the disease has less. So less aggressive in people with lesser risk factors, more aggressive in people with more risk factors. And how much do you try to reduce? The Americans say 130/80. The Europeans say first objective is bring it down to 140/90. If treatment is tolerated, bring it down to 130/80. And in people less than 60 years, bring it down to up to 120/130 also. So be more aggressive in younger people. Now, another concept, the last one I wanted to share. This is a very, very interesting study, HOPE-3 trial. In this study, they looked at people with hypertension and with kind of pre-hypertension, gave statins to them and gave blood pressure lowering. Ravinder was talking about use of statins. And what they found was statins reduced mortality even more than hypertension treatment in this, the use of candesartan. So treat multiple risk factors in these situations. And this is what we have suggested in the latest editorial also that we... Now, as Indians, we are very different. Our life expectancy is less. If you look at our life expectancy in males and females, in India is 67 years for males and 70 years for females. Look at the Europeans. Their life expectancy is 78 and 83 years. The GDP of America is 19,391 trillion US dollars. Europe is 17,000. Ours is 3,000. Health expenditure, they almost spend 16% of their GDP on health. Europeans spend 8% of their GDP on health. Indians spend how much you all know? Just 3 to 4%. Percentage of insured, almost 85 to 90%, 100% in Europe, they have insured people. In India, we all know not more than 20. So our people are very different. The kind of population, so drug cost, drug compliance, people are paying from their pocket. It's a lifelong disease. Drug compliance is the most important issue. It's not so important to prescribe the most fashionable drug or the most recent drug. The cost is going to be a biggest factor in your drug compliance as to how your patients are going to take. And so I'll end here by sharing, Abdul Kalam says India should walk on her own shadow. We must have our own development model. And so we need to treat and look at various factors. And what I'll just end here by quoting from our editorial: to achieve improved control of hypertension, the country should adopt and enforce hypertension screening and diagnosis programs in a massive scale. Protocol-driven treatments should be used, and countries like India, if they use a militant approach to combat the danger of hypertension, will make a bigger impact. These are the 10 commandments the Europeans have given. I don't want to bother you again. I've already shared some of these aspects with you, that this is the best combination how we treat our patients, and we need to manage other risk factors when we are managing hypertension. Europe, they have insured people. In India, we all know not more than 20. So our people are very different. The kind of population, so drug cost, drug compliance, people are paying from their pocket. It's a lifelong disease. Drug compliance is the most important issue. It's not so important to prescribe the most fashionable drug or the most recent drug. The cost is going to be a biggest factor in your drug compliance as to how your patients are going to take. And so I'll end here by sharing, Abdul Kalam says India should walk on her own shadow. We must have our own development model. And so we need to treat and look at various factors. And what I'll just end here by quoting from our editorial: to achieve improved control of hypertension, the country should adopt and enforce hypertension screening and diagnosis programs in a massive scale. Protocol-driven treatments should be used, and countries like India, if they use a militant approach to combat the danger of hypertension, will make a bigger impact. These are the 10 commandments the Europeans have given. I don't want to bother you again. I've already shared some of these aspects with you, that this is the best combination how we treat our patients, and we need to manage other risk factors when we are managing hypertension individuals. Thank you very much for your patience. Sorry,